All right. Well, good noon, everyone. This is Jason Crosby with Strategic Healthcare Partners. I want to thank you for joining our webinar today regarding the recently released QPP final ruling for 2023. But first, let's get started with some housekeeping. Everyone will be muted until the very end of the webinar. If you have questions during the discussion, feel free to use the Q&A or chat function on the right-hand side, and we'll be sure it's addressed. And later on today or tomorrow, you'll find a recording of today's presentation and a copy of the PowerPoint loaded up to our website. So today's focus will be related to all things QPP with some brief recap to get us all up to speed and then an overview of the final rule. Today's presenter is Aaron Higgins, who has been with SHP for 10 years now, or I'm sorry, for a few years now, feels like 10, with our analytics department and as our IT strategist. He has previously served with various private practices where he's been focused primarily on quality programs and QPP in particular. And with that, I'll hand it over to Aaron to get us started.
Alrighty, thank you, Jason. And welcome, everyone. So we got a lot to cover. We got about 35 slides to get through in the next, hopefully, 45 minutes. We'll see if we can get through it. So we're going to cover the final rule, as Jason said, and here's just kind of our flow. We're going to go through some of the minor tweaks, some of the last-minute surprise changes, the big one, the scoring changes. Those are always really big. And then we'll break down each category change and then cover the MVPs. So let's get jumping right into the final rule 2023. So about 2 weeks ago, the final rule dropped. It was a Halloween miracle occurred. I think this is the earliest final rule we've received since the start of the QPP program. So it was much welcomed. In prior years, it's usually right around Thanksgiving, which makes for a very boring Thanksgiving read. So let's talk about some of the minor tweaks. Some of these, if you're part of an APMs like an ACO or something like that, they're now allowing APMs to report promoting interoperability at the APM level. That was something previously it had to be done by the individual providers or by the groups. Now the APMs can report promoting interoperability. So if you're a part of an APM of some sort, you may want to reach out to them, see if that's something that they're planning on doing. The complex patient bonus will still be given to facility-based eligible providers that don't submit data. The complex patient bonus went away for most provider types in 2022. They're extending it for facility-based clinicians. So clinicians who are eligible for MIPS but don't necessarily see anyone in a clinic, you can still get the complex patient bonus. That's actually pretty big for y'all. So be aware of that. And then virtual groups will be eligible for facility-based measurements if 75% of the virtual group providers or greater are facility-based clinicians. What this means is if you have a virtual group, and we won't really get into what a definition of virtual group is, but if you have a virtual group and most of the clinicians in there, so 75% or greater, are non-client facing or clinic facing providers, the whole group can qualify for facility-based measurement, which is something we won't really get into. Different rules apply, again, for non-clinician types. This was a little bit of a late-minute or last-minute add-on by CMS. They are now mandating that your EHR be certified to the 2015 edition Cures update. All EHRs out there that are certified for QPP, they are 2015 edition certified. But there's now a new one called 2015 edition Cures update. I'm not really happy about the name because that's really confusing, but we'll tear this down a little bit. The big part is that your EHR needs to be updated to a certified edition before your reporting period starts if you are using ECQMs. So ECQMs are the electronic clinical quality measures, and if you're reporting any ECQMs, and if you don't know, talk to your EHR provider. you'll need to know that your reporting period starts 1/1/2023. So you effectively have a month and a half to make sure your EHR is updated to this version. So don't wait until after, because most reporting periods for ECQMs are 1 year. Some of them are 90 days, some of them are 6 months, but a vast majority of them are 1 year long. So just be aware of that. The other part that you have to make sure that you have your EHR updated before the reporting period starts is for promoting interoperability. So if you're not taking the exemption, and we'll get into those in a second, the promoting interoperability period is a 90-day reporting period. So the absolute latest, if you're not doing ECQMs, the absolute latest that you can update your EHR is next year on October 1st. To bear these dates in mind. Now, this is just ECQMs, MIPS CQMs, claims, admin measures. Those can be done on the standard 2015 edition. So just be aware. Okay. If there's questions about that, drop them in the chat or the Q&A. I know it's confusing. So let's talk about the 2015 Cures update. They are standardizing API connections. This is important because all the EHR vendors out there have kind of picked their own way of doing their APIs. They now have mandated how APIs are going to work and what formats they're going to be following. That's good for us for interoperability, sharing data between different systems. It's going to make it a lot easier. The EHI, or the Electronic Health Information Export, this is a big one, and I think those who have changed EMRs can attest how painful it is to change between EMR platforms. This is essentially CMS is mandating that you now have to, your EHR has to be able to export its entire contents out so you can import it into another EHR. It should make it easier to move between EHR. They are raising the bar to a new script version that's going to make for more secure transmission of prescriptions. There's a new standard for CCDAs, which is that CCDS that you see here. They're just changing the data set. Again, it's bringing together unified systems of operation for patient data sharing. Audit requirements. So your EHR audits all the activities within your platform. They're increasing the amount of auditing that has to happen, which should protect patient record better. And then finally, they are releasing an update that will allow EHRs to adopt new standards faster. So there's a lot going on in here. We're not going to spend any more time on it, but if you have questions, feel free to reach out to me. Be happy to help you. Okay, so there were some surprise additions in the final rules, something that hadn't been talked about at all in the proposed rule, but CMS being CMS, they like to keep us on our toes. So this one here is the physician compare. You may not even know that this exists. This is where your physician's scores will get put after reporting for the prior year. So on a scale of 1 to 5, they're scored. It's with stars, but it's a 1 to 5 scale. And someone going to go find out about a clinician, maybe they're interested in seeing a doctor, a podiatrist, they can go and they can compare, and it's based off of their quality scores, based off of maybe how expensive in terms of sort of bills that get generated by this clinician. All of that goes in to determine their quality score on physician compare. Well, CMS surprised everybody by saying that they are going to be including some more information in the physician profile. So if you don't know what I'm talking about, if you've never been on Physician Compare, go ahead and go to medicare.gov/care-compare and take a look at your clinician's scores and how the public sees it. Okay, meat and potatoes right here, scoring changes. And before I go on too far, if there's any questions, again, use the chat or the Q&A feature. We'd be more than happy to pause and answer any questions you might have. So weights and performance thresholds have changed a little bit, but the traditional MIPS, and most of what we're going to be talking about is going to be focused on traditional MIPS. Those weights are staying the same. So quality and cost, promoting interoperability, and improvement activities, they're all going to be weighted towards your total score the exact same as they were for 2022. I don't foresee, and CMS has indicated that they don't plan on changing that any further. They were mandated by law to have certain weights, and they've kept them where they are, and they haven't asked Congress to change it. The penalty avoidance score is going to stay the same. You need to score at least 75 points to avoid, and that's out of 100, to avoid getting a penalty applied to your Part B payments. And as of 2022, so this is the last year, exceptional performance is over. You will not receive exceptional performance bonuses any further. It's kind of sad to see it go away, but again, the whole purpose of MACRA was to make this QPP program budget neutral. And the only way they could do that was to remove exceptional performance. Small practice weights. So small practices are practices with 15 or fewer eligible clinicians. Their weights are a little bit more because promoting interoperability is automatically taken out of a small practice score, and we can talk about that a little bit further here in a moment. So it just changes the weights just a little bit once PI is removed. So here's a nice little graph helping you understand the shape of how the weights work out. And then this is your penalty and your reward graph. So if you score less than 75 points, it's a sliding scale all the way down to 18.75 points. So if you score less than 75, all the way down to 1875, you can get up to a 9% penalty. Anything less than 18.75, 9%. Doesn't matter if it's 18.74 or 1, you're going to get a 9% haircut on all your Medicare Part B. And then 75 points, again, sliding scale on the positive up to 9 points. So here's the small practice weight changes. And we'll talk about this on the next slide, how this works. But if you take the reweight, so if you take the promoting interoperability, automatic exemption, you only have to report improvement activities and quality. And that's weighted to 30 and 40%. And then the cost category is automatically calculated by CMS, and that'll be 30%. And then you can further claim an exemption if you're a small practice to be exempted from the cost category. In that case, improvement activities and quality are split 50-50 for your total score. So let's talk about automatic reweighting and also how it applies to small practices. So again, a small practice is 15 or fewer clinicians. Starting in 2022, you can apply for a exemption for promoting interoperability, which used to be meaningful use, if you're familiar with that. If you're a small practice, starting in 2023, that's automatic. Now, if you are doing really well in promoting interoperability, and I hope you are, but if you are doing really well, go ahead and submit your data. If you submit data in promoting interoperability through your submission process, you'll get those, it'll get scored. So if you're doing really well and you want to make sure you're getting the credit for it, go ahead and do it. And I would also say if you're doing it today, and even if you're not batting 100, that's okay too. I would still say submit it as long as you're getting enough points and it's not hurting you, because eventually that automatic reweight's going to go away. CMS hasn't said how long, but they have seen that smaller practices tend to struggle with promoting interoperability. They wanted to make the ramp easier for small practices, and so they're doing that automatic reweight. So if you're doing fine with it now, great, continue to submit. If you're not doing so hot, so it's dragging down your overall score, don't submit it. For 2022, go ahead and reach out to the help desk. They will help you get that exemption for your practice and retool for further years as you figure out what gaps you need to fill in your processes to help promoting interoperability scores. Now, the automatic reweight was happening for certain clinician types. Starting in 2023, nurse practitioners physician assistants, certified RN anesthesiologists, and clinical nurse specialists are no longer going to be re-rated to 0 for their promoting interoperability, meaning that in years past, certain provider types didn't have to report PI, much like how the small practices don't going forward. That's changing. That's going away. So just be aware that if that's something you've relied on, it doesn't apply anymore. But there will still be some providers that will be re-rated to 0. And again, small practices, doesn't matter what the specialty type. If it's 15 or fewer eligible clinicians, automatic re-weight to 0. Okay, I know that's a lot right there. I'm going to pause here for a second and see if there's any questions. Okay, I don't see anything yet in the Q&A. Again, if you do have questions, up at the top of your screen, you should have a little button that says Q&A. You can go ahead and type a question right there, and we will pause and answer it for you. Alrighty, moving along to category changes. The quality category, so that's the quality measures. You need at least 6 quality measures that you are reporting for your reporting period. They're tooling around primarily with the measures themselves, but there's some kind of higher level quality changes that have occurred. So administrative claim measures, they're using historical benchmarks, which they previously have messed around with. It doesn't really change a whole lot for the end user experience, but it's how are they getting to what sort of score you should achieve with an administrative claim measure. The data completedness is going to be 70% for 2023. So that means 70% of patients seeing their data needs to at least be included in that. Most EMRs are reporting 100%. This is primarily focused for those that are having to manually key their information from one system to another. So just be aware that if you are doing that, or you have a system in place now where you're having to manually move information between systems, that threshold is 70%. And then in 2024 and 2025, that'll move to 75% of patients. And high priority measures now include health equity related quality measures. You do need at least 2 high priority measures in your quality mix. So just be aware that there's these new measures, and we'll cover those briefly. There are 9 new measures listed here. You can find them on page 2788 of the final rule under table group A. Each one of these has a complete and total breakdown of all the steps that are required to fulfill the measure, what's its goal, and all of the reasoning behind these measures being created. There are some removed measures, so take a look at this list here. If you are reporting, and these are just the standard MIP CQM number, I'm not using the ECQM number because those are different, and not all measures are ECQMs. So if one of these numbers looks familiar, just be aware that they're being removed. 2 of them, 110 and 111, are going to become MVP only measures, and we'll talk about MVPs here in a few moments. And then there were 4 that they proposed to remove, but enough people argued in the comments of the proposed rule that they ended up keeping them, which I found fascinating. It's only happened once or twice, and the fact that they kept 4 was kind of a surprise. So the reasoning why these were removed is they were topped out, or there was a limited audience, or they felt these measures were duplicative of another measure or a new measure that was being introduced. And then in one case, they felt that it actually harmed care and didn't actually improve care at all. There are a whole lot of measure changes. There's 75 of them. So they were substantively changed. So 2 I want to call out is 130, which is medication reconciliation, and 226, which is tobacco screening. 130 is now going to require all over-the-counter medications, including vitamins, supplements, medical marijuana, anything that a patient ingests, applies, honestly, even like athlete's foot cream, things like that. that needs to be documented in the patient's record now. So they're going to be looking at that, and your EMR should be able to support that documentation going back to that certification, because there is an ECQM associated with 130. And then 226 includes all what we would consider smoking adjacent. So that's vaping, e-cigarettes, snuff, nicotine gels, chewing tobacco, nicotine patches. So anything that is smoking adjacent now needs to be documented in the patient's chart in order for you to do 226 successfully. Now, going back, 439 was proposed for removal. They instead made substantive changes to it. So it's worth looking up. That's page 3116, table group D. Cost category change. So they didn't really mess around with any of the cost category measures themselves. They did change how they're scored. So the goal with the cost is that you score higher year over year. Well, they didn't really have a good mechanism in place to do that. So they are starting to do that now. That's what they're talking about here. So starting in 2022, all MIPS clinicians will receive 0 improvement points because they're now changing the way that they're benchmarking against prior years. And so going forward, you're going to see improvement points assigned to you in the cost category. Cost category is really, really tough for practices. And again, going back to small practices can apply hardship exemption from the cost category. It's tough because unless you have a population health tool or you're buying data from clearinghouses, it's really hard for you to see what your patient costs actually are until you receive your score. And by that time, it's way too late to make any changes or argue why this patient shouldn't be attributed to you. So that's tough. Just be aware they're looking for improvements. If you want to understand this a little bit more, that's on page 2107. Some new improvement activities have come around this year, starting on page 3232. So we have these 4 new improvement activities, 2 of which are high weight and 2 of which are medium weight. You can read all the details about them in the final rule. And then there's some changes to existing improvement activities, starting on page 3239. They either got a new name and some significant changes to how they're structured, or they were so overhauled, they actually reassign which category they're in. So if any of these improvement activities you're doing, just be aware that in 2023, they may have substantively changed to the point where they're effectively a new measure or a new activity. Now, it's worth noting here, and I bring this up because someone asked me, well, I just do the same improvement activities every year. Should I be doing that? And the answer is no. The purpose of the activities is to encourage your practice to improve through the activity. And so if you're always doing the same one every year, that's going to raise some red flags with CMS. So take a look at these new improvement activities and these changed ones. Even if you had, say, done IACC 13, it's changed enough that it's probably okay to do again, but compare them and think about maybe doing a different one. There's some improvement activities that were removed. They felt that they were duplicative of another activity, or in the case of the last one, the PCI bleeding campaign, the PCI bleeding campaign actually ended in 2021. So you can't even use it for 2022. If that was on your list of improvement activities, just be aware of that. Again, the full breakdown of why these were removed starts on page 3248. And I will be linking here in the chat before we're done the exact place you can download and look at the final rule. Promoting interoperability changes. There's a lot going on here. And again, if you're a small practice, maybe you just want to zone out and go browse Facebook or something while I talk through this. But this is important for, I think, everybody to know what's changing and how it'll affect your promoting interoperability. Starting on page 2254, table 92, the PDMP measure. So that's the opioid database where you query the database to make sure that someone isn't doctor shopping or drug seeking. The PDMP is required participation in the state of Georgia. Other states don't yet have that requirement. So if you're in the state of Georgia, you need to be doing querying the PDMP anyway. So this should be an easy one, but they're now changing the participation. It's now required. So regardless of what state you're in, if you want to participate in promoting interoperability, you now need to participate in a PDMP. And it covers all Schedule 3 and 4 opioids, no longer just the Schedule 2 drugs. They've created a third option for the HIE objective measure, and that's attesting participation in TEFCA. You can only do that once. In future years, the answer has to be either you are or you aren't participating, in the sense of if this year you say that you're going to be participating and you have a letter of intent, the next year you need to actually show that it is operating. You have 1 year or less, depending on when you get engaged, to show that you're actually participating in a TEFCA. And if you don't know what that is, talk to your EHR provider. They can provide you some more information on it. There's some minor score changes. ERX is staying the same. PDMP query is 10 points. It's no longer 10 bonus points like it was in prior years. The HIE is worth 30 points now. It used to be worth 40, but because they're making the PDMP 10 points and mandated, they reduce the HIE participation. So there's 3 ways to participate in the HIE. You can either support electronic referral loops by sending, receiving, and reconciling. There's a total of 2 measures involved with that. Each one of those 2 measures are worth 15 points. Or be a part of an HIE that has bidirectional exchange, or participation in the TEFCA. Also provide patient electronic to their health information. That's typically done through a patient portal. And then you have to report 2 measures of participation with an immunization registry and electronic case reporting, or be able to claim an eligible exemption. There's information on the QPP website on what is an eligible exemption for that, such as if you are a cardiology practice, you're not typically documenting immunizations or reporting cases in your state. Maybe your state doesn't have a registry for electronic cases. Those sort of exemptions are available. And then you need to report one of the following 3: syndromic surveillance, public health registry, or clinical data registry. This one's harder to claim exemption on anymore. There are so many clinical data registries out there. Odds are your EHR vendor probably has one that is very easily turned on with a click of a mouse and a small payment or monthly access fee. So check with your EHR vendor, see if that's something available to you. And then a change to the level of participation with the HIE measure. They're combining some of the options into a single one, and they're doing the same with the public health and the clinical data exchange measures. I'm glad they are. It's some technical cleanup. It makes it more easily understood by those that may not be familiar with all that language. Okay, well, we'll pause here real quick. If there's any questions, if you need me to slow down, maybe go back and talk about something else you saw on one of the slides, I'd be more than happy to do so. Just drop a message in the chat or in the Q&A. Okay, I don't see anything there, so we'll go ahead and move on. Talk about MVPs. So the MIPS value pathways, because the government likes to create acronyms and initialisms out of other acronyms and initialisms. So MVPs. So these were introduced or signaled in 2020. And what they really said is that they had received a lot of feedback that MIPS and QPP was very confusing. It was a lot of guesswork, a lot of research having to go in, and they wanted to streamline it and make it more easy for someone to approach who's brand new, green out of the gate on how all this works. So they said, we will sunset traditional MIPS and introduce MVPs. Well, everybody panicked a little bit. And then CMS clarified shortly thereafter saying, no, we'll sunset in about 10 years. Yeah, so now we're looking at the actualization of this happening. So what is MVPs? They're pre-assembled list of quality measures, improvement activities, and cost measures that are roughly based on the existing quality specialty measure sets. So it's hand-selected, so to speak, curated lists of measures and improvement activities that other people in your specialties are already doing or will do together. And so when you're an MVP or in an MVP, you'll be only compared against other providers in the same MVP. Right now, when you perform in MIPS, traditional MIPS, if you pick measure 226, that was the tobacco measure, you're going to be compared against any and every clinician type that selected 226. In an MVP, if 226 is one of the measures, it will only be compared against other people in the same MVP performing the same measure. So in theory, it should make your performance more realistic based off of your MVP type. Now, they've tooled around, and we'll get to that here in the next couple of slides. They've tooled around with what is an MVP and what all goes into that. So right now, MVPs are completely voluntary, and next year will be the first year that you can voluntarily participate in them. And then in 2026, so we're looking at 3 years from now, MVPs are going to start becoming mandatory. So they've added some more MVPs. They've updated the names of the MVPs that they had already proposed, and they're continuing to tweak what measures and improvement activities are going into them. And then there will be 5 more added for next year. So these are the first 7 MVPs. All of them were renamed. And then the additional 5 you see over there on the right. So they were originally focused on provider specialty, but then they realized that's not necessarily always the case. You may have someone who has a primary taxonomy, but maybe they're practicing differently. Maybe they're just an internal clinician according to their taxonomy, but they're hyper-focused on heart disease. Well, we'll just go with that one. So they realized that wasn't really a good idea to just be based off of taxonomy. So now it's going to be up to the practice or the individual provider to select which MVP they want to participate in. And again, they're also named a little more thoroughly so you can understand at a glimpse of what all is going in and what sort of scope of care the clinician does and if this applies to them. So typically in MVP, you only have 4 quality measures versus the 6 that are required. You need to still perform 2 medium-weighted activities or 1 high-weighted activity. So the improvement activities are reduced by 50%. Or if you participate in a PCMH. The cost measures are pre-selected for you. It's a much smaller pool and again, more hyper-focused on what the MVP is all about. There will be 1 population health measure. And so the population health measure will either be an improvement activity or a quality measure. And it's going to vary from MVP to MVP what that pop health measure is. But it's an existing measure that's either an improvement activity or quality measure. It just, so effectively, potentially your MVP has 5 quality measures because one of them is a population health. Or you have 1 high-weighted IA, and then you have your pop health IA. So just be aware of that. And then, of course, promoting interoperability. No matter what people try to do, you can't escape promoting interoperability. It's there. And again, going back to the small practice, they have not said if a small practice participates in an MVP, if that means they're exempt from promoting interoperability. I looked to see if anybody had asked that question. I haven't seen it. I'm looking for an answer. I'm going to call help desk after the 2023 reporting year starts and get an answer about that. So an MVP, so MVP registration, again, it's self-nominating. You can nominate early on voluntarily, but once you're in, you're in. You pick your MVP between April 1st and November 30th of the performance year that you are in. And that will be through the MVP portal, which isn't live yet. Unless you are a CAPS participant, your deadline will be June 30th. That's because of CAPS deadlines, not CMS deadlines. So in 2023, 2024, and 2025, anyone can report an MVP. You can see how that is broken down. And starting in 2026 plus, there's going to be additional changes. Now, multi-specialty groups come 2026, you're going to have to submit subgroups. You don't have to do that in the volunteer years, but in the mandatory years, a multi-specialty group is going to have to submit subgroups of the different MVP types. So you can't lump everybody in. Say you're a multi-specialty and you have cardiologists in your group. You can't do the promoting wellness and include your cardiologists in that. They're going to have to be in a cardiology specific MVP. Let's talk through some pros and cons, and we're almost done here, folks. So bear with me just a couple more minutes. So the pros and cons of participating in MVP, and again, this will be mandatory in a few years, so maybe you do want to do this a little bit early. Their argument is that there's less administrative burden than traditional MIPS. All of the selection of which of the 200 some odd measures am I going to do, that goes away, and you're given a list of 6 or 7 to pick your 4 from. So that makes it easy. There will be fewer measures for you to track. Overall, there's just less to follow along with. And it's going to hopefully make for some easier scoring, you to understand. But there are some cons, there's some downsides. Which MVP do you select? And understanding that it might be confusing early on. You need to remember to register ahead, and you can't register on the first of the year. You have to wait until April 1st. Your EHR needs to be able to support all the MVP measures that you're wanting to do. So you need to reach out to your EHR vendor, just make sure, hey, I'm interested in this MVP. These are the measures. Do you support it? You need to be aware of that. And some of the measures that you may have been reporting in years past may be going away and not in your MVP. So you may need to retrain and start whole new processes again. So there is a downside. It may be something that you want to consider doing now, though. Again, going back to this will be mandatory in 3 years. So getting a leg up on it may be beneficial. I think CMS is going to judge the volunteers less harshly because they know it's a new program and they're trying to learn some lessons from it. So MVP toolkits, these are available on the QPP resource library. Select performance year 2023, and the 7 MVP toolkits are available now, and the newly approved is what it should have said. 5, they weren't added last I looked, but they may be up there today. I didn't go looking for these today, but they weren't there last week when I looked for them. So just be aware, if you're interested in the MVPs, you want to understand what all measures they're covering, everything that goes into them, you can find the information here. Okay, so here's the big piece. What do you need to do next? When we hang up on this call and you have questions, feel free to reach out to me. Read through the final resource packet, and I will be dropping a link to that here in a moment into chat. This is the full final rule. And then we have the final rule resources. And in there are some easy to digest and understandable PDF files that will help you understand the final rule at a glance. But if you wanted to read into the breakdown of your favorite measure what has changed or why was it removed. All that information is going to be in the bigger final rule. That's the first link. The second link is the final rule resources. It's about 4 or 5 PDFs that'll help explain in some greater detail what we talked about today. Consider taking the automatic exemption if you are a small practice and you're not doing terribly well in PI, or PI has been historically a challenge for you. But also, if the opposite is true, if you're a small practice and you've been doing really well in PI, consider just submitting your data. There's no harm in you submitting your data if you're doing really well. Also consider voluntarily participating in an MVP. Like I said, CMS is going to judge those a little bit nicely, and they're going to have a lot of resources available to those who are volunteering for an MVP. It may make some administrative burden on you overall less. So it's definitely going to cause an administrative burden early on as you're learning something new, but over time, it should be less on you. And then be sure to reach out to your EHR vendor. Find out if your EHR is 2015 edition Cures certified. That's a mouthful, but you need to use that language specifically because your EHR is currently 2015 edition certified. It's that Cures. That's the important part. And you need to do this before you do your quality measures if you're using ECQMs. If you're using MIPS, CQMs, or any of the other quality measure types, you're okay. You don't need to panic. And if you need to make sure it's done before you're promoting interoperability. So if you're not going to opt out of promoting interoperability, you need to make sure your EHR Cures edition is in place before your reporting period. So the absolute drop dead date will be October 1st, 2023 to make sure that update is in place. Already, there are some official resources. There's the official resource library. If you don't get the links that are in the chat right now, you can reach those same documents there at the resource library, or you can always call the QPP help desk. I call them all the time. I get questions or oddball situations, and they are always extremely helpful. And they may not be able to answer you right away, but they will work hard to get you an answer. I think a coworker of mine can attest to that. It took us about 2 months to answer a question because it was so complicated, but CMS QPP helped us, was there the entire way. Alrighty. Well, if you do have questions and you want to ask them now, this is the perfect time. We're about 15 minutes to 1 o'clock. So you can drop them in the chat or the brand new Q&A feature that is listed up there at the top. Or if you want to ask your question out loud, you can raise your hand and we will unmute you and you can ask. Or if you want to drop off, feel free to do so. We'll be around for a couple more minutes. You can also shoot me an email. My email address is ahiggins, that's ahiggins, at shpllc.com. Be more than happy to help you out, set aside 15, 20 minutes, have a quick chat about what sort of QPP questions you might have. Alrighty, well, if there's no more questions, then I give you 15 minutes back to your day. And as always, feel free to reach out. Jason, you want to land this plane?
Yeah, thanks, Aaron. Lots of information. Again, please look for today's presentation and recording on our website, hopefully later today, if not tomorrow. As Aaron mentioned, you all look at our information, please feel free to reach out. I know we covered a lot today, so a lot of information. And look forward to our next webinar and podcast that we'll be launching here soon. Thanks to all for attending and have a great rest of your day.